Good morning. For those of you who don't know me, my name is Rob Brown. I'm the Associate Head for Education in the Department of Anesthesia. And I'd like to welcome everybody to our combined rounds between anesthesia, surgery, obstetrics and gynecology, and diagnostic services in Manitoba. And this rounds is to kick off Blood Day, as I assume you know since you're here. And my role today is really just to introduce our speaker. I've known Brian for, Dr. Brian Muirhead is our speaker. I've known Brian Muirhead for a very long time, in that I'm not really a junior member of the department anymore. And Brian is currently an assistant professor in the Department of Anesthesia. He's been interested in blood, all things blood related, particularly its conservation and management, for the last 25 years. In that vein, he has had many positions related to blood management. I'm going to apologize. I have to read it off my phone because I forgot to print it. He's been the chair of the HSC Transfusion Practices Committee for 13 years, medical director of the WRHA Blood Conservation Services since it started, national chair for the Physicians and Nurses for Blood Conservation, National Blood Safety Council member from 1999 to 2001, lectured extensively on this topic through Canada, and currently is the chair of the National Advisory Committee on Blood Products for the provinces and territories, co-chair of the National Emergency Blood Management Committee, and has recently chaired the committee which developed the recommendations for fibrinogen concentrate in Canada. So Brian's been very busy in this area, so I will yield the podium to him.
Thanks a lot, Rob.
Welcome.
Thank you. And welcome to everybody. This is I think this is our 9th Blood Day. You can tell it's Blood Day because it's a take your kids to work day. That's how we. And Rob suggested for blood we should do it, just before Halloween and we can get dressed up. I'm going to do a couple of just basic things. So that's where you can, if you want to get accreditation or your attendance, just use your username, visitor, password. I know different departments have different ways of doing it. The other way that we have it can be done, sorry, let me just get this organized. You can go to Best Blood Manitoba, which is a website that was developed by Blood Conservation Services and Diagnostic Services in Manitoba. It's a great website, and I would highly recommend it. The learning objectives are down there, but basically I'm going to go over what Choosing Wisely Canada is about, what the recommendations from the CSTM are, and to learn how these recommendations will affect clinical practice in Manitoba, and they're going to affect clinical practice in Manitoba, hopefully. There are some problems when you try to get the blood education across the various groups, but I think that Choosing Wisely Canada is really going to help. I have no conflicts of interest, nor I have received on the regular industry in the last 5 years. And to go backwards. Just to remind you that this whole week is actually Blood Management Awareness Week. We are running lectures every noon hour at the site building. We also are going out to visit some other hospitals in Winnipeg. We had some coffee and dainties in the foyer after the grand rounds today, and check our display in the main concourse display area. Okay, sometime today we'll be there. Choosing Wisely. Choosing Wisely actually Canada is modeled after Choosing Wisely campaign, which is put on by the ABIM, which is American Board of Internal Medicine, in 2012. Okay, it was launched there, and basically the goals were to reduce unnecessary tests, reduce unsafe tests, and hopefully there might be an economic benefit by doing this, although that was lower down the list. The goal of the American Choosing Wisely was to reduce the number of tests and procedures in the United States by 10 million by 2020, and they are on track to do that. Choosing Wisely Canada's campaign to help physicians and patients, like I said, it's modeled after that. We initially started in Ontario, and this is within the last 2 years, and it's been basically adopted by all provincial and territorial medical associations. And it's truly a national campaign. It's spread to an international campaign, and Choosing Wisely Canada is actually very much a leader for the international effort. As of June 2nd, there was 49 new recommendations, and basically they went out to various societies across Canada. You can see emergency medicine, hospital medicine, nuclear medicine, pediatric surgery, psychiatry, spine, transfusion medicine, and vascular surgery. And since then, the Canadian Anesthesia Society has been added to this, and Tom Mutter's talk a few weeks ago was based on their 5 recommendations. So today I'm going to talk about what the transfusion medicine recommendations were. They do have a website. I think it's very important to follow. This affects not only clinicians, but anybody involved in healthcare, whether it's administrative or anything else, actually. So the CSTM, actually, they initially had 5 recommendations last year, which were accepted by Choosing Wisely Canada, and they had a further 5 recommendations accepted this year. So they're actually leaders. They have 10 recommendations out of, last time I counted, there were 61 recommendations of Choosing Wisely Canada. But we're still waiting for other input from other national and provincial associations. So I'm going to go through the recommendations. I'm going to make some comments. I think you're going to learn some things. There's some very much, there's a local and regional flavor to how some of these things are going to be interpreted. There are some problems in Manitoba that are unique to Manitoba that you don't see across Canada, and they're going to have to be addressed. So recommendation number 1, don't transfuse blood if other non-transfusion therapies or modalities are available. Sounds very simple. This is a case in Toronto where a 32-year-old female, actually at the 12K point of a marathon, actually got acutely short of breath and presented to emergency with a hemoglobin of 61, was transfused with 3 units of red cells, had a history of menorrhagia. Her serum iron was 2. This woman is not symptomatic, and I think you have to, if you transfuse, you hope to have some sort of symptoms or signs, okay? She was not symptomatic because she just ran 12 kilometers, and at rest she was fine. So if she got 3 units of blood, well, all she needed was IV iron. IV iron would have kicked in within a day or 2, and she would have been retaking within 3 days. The problem when you give a person red blood cells, you've given them an iron load, okay? Their ferritin, their serum iron would going to be up. It might be dysfunctional iron. So when people are looking for IV iron in the blood conservation services, one of the things we discourage is blood transfusion when all you need is iron. And if you get transfused, we're not going to give you iron because you might have an iron overload after your transfusion. We had one in actually emergency on Friday. We got consulted on when there's a woman with a hemoglobin of 33 that presented to emergency. I'm glad they consulted us. I didn't have a chance to go see the patient. They were going to transfuse her for 3 units. I discouraged that. I said, 2 units, because there has to be a degree of, you have to feel comfort. And a lot of people don't feel comfortable with a hemoglobin of 33, although I do. Not that mine's 33. So iron therapy is one of the mainstays. When you look at other modalities that can avoid blood transfusion, I think the cell saver, if it's used correctly, has huge benefits. It's the only absolute contraindication for using a cell saver is fecal contamination and hepatocellular cancer, where you might fracture the tumor in the liver. There's 2 good ones. Trudeau and out of Vancouver at UBC came out with an excellent review, and read that. We should be using the cell saver a lot more, or we could use it a lot more. The one caveat that I remind you with the cell savers is if you're using a leukocyte depleting filter, which you have to if there's sepsis or cancer cells, they recommend it. They recommend it for amniotic fluid too, but you can actually wash away the amniotic fluid. You don't have to use a leukocyte depleting filter. Beware of hypotension. The filter is a negatively charged filter, and yet will throw your bradykinin levels up to 1,000-fold if you are on ACE inhibitors. And there's some good case reports. So always beware of a person who gets cell saver blood through a leukocyte depleting filter only, that they may be prone to this, and watch for hypotension. We don't get it from regular blood cells anymore because all blood at CBS goes through a leukocyte depleting filter, and the charge is gone within hours, okay? That's my baby, okay? It's a new one. She's 33 feet long. Recommendation number 2, okay? Don't transfuse more than 1 red cell unit at a time when transfusion is required in stable, non-bleeding patients. We made our our name known in blood conservation by just changing. There was a routine transfuse 2 units order in post-op hips and knees at Concordia. And one of the ways we got funding for him, we said, don't transfuse 2, just transfuse 1 at a time. In surgery and anesthesia, you can say, come on, Brian, we can't just transfuse 1 at a time when they're bleeding out. And I agree, when they're bleeding out, it's a different story. And why are you worried about the units? Okay, well, there's a couple of things. I don't buy people hate me for this, I don't buy the infections. I mean, the chance of getting HIV are 1 in 13 million. Hep C is probably 1 in 6 million now. Hep B is even actually dropping. It used to be 1 in 80,000. It's a lot less. The tests that they do on blood products pick up most pathogens, okay? Having said that, every 7 years a new pathogen enters. The other thing that I'm concerned about is anemia being a protective response in patients who have cancer, patients who are septic. There's good literature now that you give a person iron and they're septic or they have an infection, the pathogens just love it. They thank you for it, okay? And if you look at people get transfused, they have a higher incidence of in-hospital stays because of infection. And the same thing's been shown if we give IV iron. So we can't give IV iron to a person that's got an acute infection, or we won't do that. Cancer, Houston and Zarachansky put a paper a few years back talking about maybe it's a protective mechanism. It affects hepcidin, so you change your absorption of iron, but maybe the tumor cells like to have a oxygen delivery-rich blood supply, and maybe it's best to keep them with a low hemoglobin. The whole immunomodulation, we do know that the inflammatory markers go up after a blood transfusion. I think the leukocyte depleting filters have changed some of that, the immunomodulation, but it's still a problem. And if you look at a hospital that does not do transfusions, they have much better length of stays, they have much better outcomes and less mortality, morbidity rates than people who do get transfused. So it's necessary many times, but we have to justify that we're doing the right thing at the right time. I still say transfusion is a clinical decision based on symptoms and lab values. And if a person's hypotensive and they got blood on the floor, I don't wait for the hemoglobin to come back before I transfuse. I think most people are like that. However, I'm indifferent if a lab value comes back at 72. I might not transfuse them, okay, unless they have clinical symptoms, if they're hypotensive and there's ongoing bleeding, which is a key thing, and why we cannot sometimes transfuse just 1 unit at a time. We have to give 10 units in about 12 minutes. One thing that I think we do in the post-op period here that we should look at is if you're considering giving a person a transfusion, say in recovery room, take a look at how much IV fluid they've had, okay? And if they're not hypotensive and no ongoing bleeding once again, but if their hemoglobin is 65, I don't transfuse them when I look and see they've received 5 or 6 liters of crystalloid because the hemoglobin will come up. If they're bleeding, I change my mind. I've been known to give Lasix to get the hemoglobin up in that scenario too. But like I say, it's a clinical decision. It's the same thing with plasma. I think you've heard me talk about this before. If a person has an INR of 2.1 after receiving 17 units of red cells and they're not bleeding, I don't give them plasma. And I think the key thing is learn to be comfortable with low hemoglobins, and that's a real tough thing to sell. There are some people in obstetrics who are more comfortable. We've sent a patient home with a hemoglobin of 448. Okay, she did fine with iron. People are uncomfortable to have a person with a hemoglobin below, whether it's 80, 70, 60, or 50, whether they have heart disease or they have some other chronic illness. So I've been doing this for a long time, and I'm comfortable with a person who's asymptomatic, who's not bleeding, and has a hemoglobin and otherwise healthy of 40 or 50. In that range. Recommendation 3, don't transfuse plasma to correct a mildly elevated, which is 1.7 or less INR, before a procedure. Alan Timoth actually looked at the use of plasma in Canada and what the indications were for it. An elevated INR, we have to remember, is a measure of warfarin therapy, okay? It's never been normalized to liver disease or stuff, the INR that we use. So it is a measure of warfarin therapy. I think if you've been involved with a person that has a prolonged INR from whether it's liver things or some other chronic illness or disease going on, it's hard to get them better than 1.7. Certainly, I don't see people getting to 1.1 or 1.2 or even to 1.5. Very, very rare, unless it's warfarin therapy, okay? And this has been shown time and time again that it's hard to get them down in an ICU setting. I think where your exception might be if they're bleeding in the head or if they had ongoing bleeding. There is no evidence for increased bleeding in mildly elevated INRs for invasive procedures, okay? Unfortunately, the radiology societies and ASRA do not agree. And I think that's one of the conflicts you're going to see when transfusion medicine people are talking about when we should use it, making the recommendations. And we have, the ASRA saying, which is the American Society of Regional Anesthesia, saying, no, if it's above 1.5, you can't do an invasive procedure. Recommendation 4, don't routinely transfuse platelets for patients with chemotherapy-induced thrombocytopenia if the platelet count is greater than 10 by 10 to the 9th in the absence of bleeding. This is just for chemotherapy-induced thrombocytopenia, but certainly from the Emergency Blood Management Committee, what we're looking at is if there's a shortage of blood, our platelets are gone. We don't have much of a shelf life of platelets. They have a shelf life of 5 days right now in Canada. The first probably 30 hours they're not for release yet because they have to go through bacteriological testing and some other tests before they're actually released. So we have around roughly about 3.5 days of shelf life of platelets. Okay, so whenever there's the threat of a shortage, the platelets are going to be the first to be affected. We had one in January. There's going to be 700 union workers walking out of Ontario, and they did a last minute at midnight resolution. But we would have had a platelet shortage within 3 days in Manitoba. And we do have a plan, and where all cardiac surgery would have been canceled, and it's been supported by the provincial governments. So it's the most vulnerable product during a blood shortage. In Quebec, they're looking at, I think they might have already done it, they're going to extend the shelf life to 7 days. They've done this in other European countries. And probably consideration for more conservative guidelines. Those would be if a person has ITP, don't transfuse them unless they're bleeding. And I had one with a platelet count of, I think it was 18,000, and he didn't get his IVIG from the hematologist, and he was upset. And I said to Brendan, let's go ahead with the surgery. We'll have platelets available, but I'm not going to give him platelets. And certainly, the golden numbers of 50,000, 100,000, certainly in the blood shortage, those are going to be looked at differently. The amount of platelets we're going to give would be different too. We're going to there'll be aliquots of platelets. Instead of getting to 5 units, you might only get 3 units. Okay, we might be splitting platelets, which we'd have to do in a shortage, and that plan is in place. Recommendation number 5, don't routinely use plasma or prothrombin complex concentrates for non-emergent reversal of vitamin K antagonists. This is one of the ones that's seriously abused. It's seriously abused in Manitoba for other reasons, which I'll go into a bit later. Warfarin Reversal, 10 milligrams of vitamin K, okay, IV, not IM, will reverse most vitamin K antagonists within 6 hours. So if you're not bleeding and you do have time, go this route. The chances of anaphylaxis from vitamin K they're just not there anymore. Like that was what everybody, when I was going through medicine, you couldn't give vitamin K IV or IM because you had to watch them like a hawk because they would drop their blood pressure and go into anaphylaxis. The other thing that I was taught, if you give a person a vitamin K therapy to reverse warfarin, that their liver is screwed for the next 7 to 10 days because they can't make 2, 7, 9, 10. And speaking to my hematology colleagues at NAC, this happens maybe 1 or 3% of the time. You actually will not be able to reproduce your liver-dependent, your 2, 7, 9, 10 factors. So don't let that scare you when the person is on. You can start the warfarin therapy right after rather than having to go on dalteparin or heparin for people who are at high risk of developing thrombosis-type symptoms. These are the NAC recommendations. We put these out 2 years ago. One of the problems with NAC is there's 14 hematologists and hematopathologists that won the NASA test, okay? And it's most of the hematologists have not been in the OR setting, so I have had some concerns with the guidelines. The other problem we have is there are some hematologists in Manitoba that say don't use PCCs. So hematology has to get their act together too about what is the right things. So every provincial hematologic society has their own. Our NAC ones are based on representation from all provinces, and basically the quick way of doing it, if your INR is less than 3, give 1,000 units, which is they are measured, the units are factor 9, okay, so that would be 2 vials if you're using the 500 unit one. 3 to 5 would give 2,000 units, and greater than 5 would give 3,000 units. If the patient's unknown INR, don't wait for an INR and they're bleeding, you know they're on warfarin, give the 2,000 units. And that's basically the recommendation. We are looking at weight, you know, could it be weight specific, and about repeating doses. But those concentrations are a very good starting point. That's taken from my boat that's 300 yards. It's a bald eagle with a 400 millimeter ultrasound telescopic lens. And he just died right after that. It was so clear I could tell it was a he. Sorry. Okay, recommendation number 6, don't use immunoglobulin therapy for recurrent infections unless impaired antibody responses to vaccines are demonstrated. IVIG is one dose, okay, it's $5,000 to $10,000 for one dose, and most people don't realize it. It's about $65 a gram, okay, and there are some on-label recommendations for IVIG, but the off-label ones have really taken off. Some of them are very effective, and they work in some chronic diseases. That $5,000 to $10,000, IVIG is about 25% of the CBS budget. They're spending about $250 million a year on IVIG in Canada, so it's huge. Canada is the #1 user of IVIG in the world. Okay, once again, we're #1 there. Europe, they don't use as much, and Australia and the United States are catching up or are very close. As I said, there's many off-label indications. NAC developed guidelines years ago, but we went to the societies. We went to the neurology and said, develop guidelines, please, and went to hematology, develop guidelines. We published guidelines about, must be 8 or 10 years ago. And it was Catherine Moulton actually headed that up. And since then, we're in the process of redoing it again. And the hematologists and neurologists are pretty much on board. There's a lot of chronic neurological conditions that do respond to IVIG. What we need guidelines for are dermatological and rheumatological indications. About 20% of IVIG use in Manitoba right now, and I looked at the last year's figures, are used for things like chronic urticaria syndrome, which I'd never heard of. I don't know if it works, but they have to develop guidelines. IVIG has not been threatened to be in a short supply recently, but in the past it has been, and we've had to. Our transfusion medicine had to monitor how it was being used and actually turn down people who are being used. So there is, the primary IVIG deficiency is one that's well known. Toxic shock syndromes, group A strep, it's been shown to be effective. But there's a lot of them, and when I looked at the indications in Manitoba, there was 48 different indications, okay? And a lot of them were dermatological and rheumatological, and some weird ones for neurology, but at least they'd done their guidelines and they'd done their studies and they published it. Recommendation 7, don't order unnecessary pre-transfusion testing, type, and screening for all preoperative patients. And this is a real problem in Winnipeg and Manitoba. The type and screening in the WRHA is done by CBS. Okay, and in the outlying, more rural health authorities, there are some places that will do. The hospital does the type and screening, the cross match, because of distance. About, I guess, gosh, it might be about 15 years ago now. We were looking at, and this is when we were worried about Hep C was out, and we were worried about pathogens in the blood, and we looked at what the guidelines were, and there weren't very many guidelines, so I did an audit of who orders blood for what procedure. This is operative procedures. And carotid endarterectomies would get cross-matched 2 units. AAAs got cross-matched 6 to 8 units back then. And what I did is I looked at 80 different procedures, and I developed, based on how much blood actually they got, to change them from group and match to type and screen, and to change the number of units from 6 units down to 2 units, because in those days, you had to have the blood available. The cross-match had to be done. The blood was sitting there. I think type and screening, there are some models out there that we should be using. It should be based on maximum allowable blood loss, okay? Include the hemoglobin, the weight, the gender, and the procedure. I think if a 90 kilogram 70-year-old man with a hemoglobin of 150 is going to go for a total knee, his maximum allowable blood loss is around 2,700 mLs of blood. And most surgeons in a total knee don't lose that much, okay? So in my mind, he doesn't have to be type and screened. There are some caveats to it. If he's a rare blood type, if he's known to have antibodies, then he should do a type and screen. But it's a waste of time. I'll get back to that actually in a bit. A type and screen is good for 3 days, okay? And everybody complains about, why do we have to repeat it every 3 days, okay? A lot of the problem is because of geography, okay? A lot of problem is we didn't know if people were getting transfused, okay, why they had blood in the hospital, and because if you get transfused, you have to do another serious cross-match or type and screen. If it's drawn in the pre-anesthesia clinic, this is in the WRHA region, it's good for 21 days, which saves a lot of problems. One of the problems we have, I know at Health Sciences, and I'm sure it's at other hospitals, is you get a patient coming in the morning, and for the type and screen hasn't been done, so please do a type and screen, and we'll send it off, and we proceed with the surgery. In PAC, that 3-day rule applies, though. If they've been transfused in the last 3 months, there's a 3-day rule for PAC, okay? 75% patients who get cross-matched have been type and screened or cross-matched before in the health system. There are a lot of people out there who've never been type and screened. The ones who have been usually have had it done before. And you can develop antibodies anytime 3 months after blood transfusion. That's why we have that 3-day rule, which would apply even to PAC. Getting back to the patient, let's go back there. So a patient comes in the morning, and the example I'm going to use is the one I had 2 weeks ago over at Women's. It was a debulk of a vascular tumor. We didn't know it was vascular at the time, but a type and screen hadn't been done, so we drew one off the morning of her surgery. She ran into bleeding about 30 cc's a minute, an hour into surgery. Okay, called for the type and screen hadn't been done yet. Okay, she needed blood. So what do? I'll go into what I did later because I use it as an example. But we have to decide. And CBS, 40 to 50% of their type and screens are sent to them as a stat request. Okay. And on any given morning, they could get 8 to 10 stat requests from people coming in for their elective surgery because they weren't seen in PAC or they were unable to have their type and screen done usually because of where they came from. It's going to take, and they'll admit that it'll take 1.5 to 3 hours to do that type and screen. Okay, if they get 8 or 10 of them, there's the transportation problem. Health Sciences is nice and close. Other hospitals aren't nice and close to CBS. So there is that delay. We expect to be waiting for 3 hours before you actually have a type and screen done. And I think we have to decide then, do you delay surgery? Okay. And I think if we use the maximum allowable blood loss, we can take a serious look at do we need a type and screen? And I'm canceling my type and screens in the morning because I'm saying, the surgery's going to be over by the time they have a type and screen, and I'm not convinced it's going to be huge blood loss. And that's why God gave us emergency blood, in case you get caught in this situation. It works as long as you know they don't have antibodies. If they have antibodies, I think you should seriously consider, we have to change the system so that type and screen is done rather than the morning of surgery, because CBS is overloaded and they can't produce as quickly as we want for a stat request. Or you have to say, what is a stat request? Don't type screen anybody. But when they start bleeding, you send out a stat type and screen. So I don't know if we delay the surgery. We've had this a couple times. We had this one with a cesarean section that was being done in the main R, where her type and screen ran out, so she had to be retyped and screened. Do we wait? And there are other things we can do, but I'm very conflicted about what I would do in that scenario. Do we cancel the cesarean section until we have the type and screen in the hospital? Once we have the type, then the type and screen costs $54, and we asked that. Once they have the type and screen, with electronic cross-matching, the cross-match takes 5 minutes. So any other delay after your type and screen is transport, okay, which can be a huge delay in some areas. Recommendation 8, don't routinely order perioperative autologous and directed blood collection. They did directed donations in Japan, and they had about 30 kids that got graft versus host disease. They have to irradiate directed donations. They also found out that the directed donations, they came from family members. They were not honest or truthful with their screening process. You know, Uncle Joe is not going to say, yeah, I've spent my life doing this. Okay, he'll hide it. So it's basically it's unsafe, and it's very, very rarely used. There's an increased transfusion risk for both these, both the autologous. A person pre-donates. They go through our blood conservation program. We do a few. I like to do it for people that you know they're going to lose a lot of blood. They are motivated to take iron and keep their hemoglobin up, or they have a rare blood type. And basically, it's a rare blood type, which I think is the most important one. Most patients, if they don't go through the blood conservation program, arrive, they got the 2 units of red cells in the bank, and their hemoglobin's 110. Okay, and you've lost there's no gain there. We've had patients who their blood has been contaminated during the process of taking their blood, so not only do they lose a pint, but they don't have it anymore in their fridge. So we really discourage it, and I think anybody who's considering it should go through a blood conservation program so we can decide. But I think we probably do maybe 20 at the most a year. I don't know if I think that might even be high now. Once again, rare blood types and rare antibodies, we would recommend it. Interop autologous collection. There's only 2 in Canada now, I think, that do it, but I still believe in it. It may have a role in certain conditions, and the condition I use, it's not for the red blood cells, it's for the plasma and platelets you get back from taking off 800 cc's of whole blood, and that will save them a plasma and platelet transfusion if they get in the process of losing a lot of blood, and you have a cell saver that's collecting the red cells but not the plasma and platelets. Recommendation number 9. Don't transfuse O-negative blood except to O-negative patients and in emergencies for female patients of childbearing potential of unknown blood group. That patient I spoke about, you know, it was interesting. When she was bleeding, I needed blood. So there's 2 units of O-negative blood at women's, always there. She was no longer of childbearing potential. So I asked for 2 units of O-positive, okay, which the blood bank was gracious, and you know, they got there right away, and we had to send our own transport, but it was highly effective. One of the problems we have in Canada, and it's actually changing because of immigration and because of the blood types are actually changing. I just want to point out, and everybody knows who the universal donor is, right? Yeah. Wait till I get to the plasma. So O positive is still the most common in Canada after A positive, and this is the distribution of the blood types in Canada right now, and this is the numbers that are issued. And as you can see, one of the problems we have in Canada is that 7% of the population has O-negative blood, and almost 12% there's requests for O-negative blood. For O-positive blood, which is the universal donor, unless you have a childbearing potential. We had to use the wording very, very carefully because there have been 58-year-old women that have had babies now. But it's also the potential. So it's women who are in the childbearing ages or before the childbearing ages who have the potential. If a person's having a hysterectomy, you don't have to use O-negative blood because they're female. So this is if you don't know the blood type. So our problem right now is we have a shortage of O-negative blood, okay? And so we have to really, the blood bank has been great in really promoting, and our ORs are stocked with O-positive emergency blood. Most clinicians now know that you can give O-positive blood. There's a few who don't, but it's something we have to correct. Red cell use actually in Canada has dropped off about 3 to 5% over the last 4 years, okay, which I think is due to better understanding of some things, and some of the education I think is finally seeping into some, what I thought were, at one point were closed minds. Recommendation 10 is don't transfuse AB plasma to non-group AB patients unless in emergency situations where the ABO group is unknown. And what is the universal donor for AB, or I give it away, for plasma? Everybody says, well, it's AB positive. And some people say it's AB negative. Well, basically it's AB, because it doesn't matter when you go the other way. So distribution of plasma in Canada becomes a bigger problem, and then when we look at the AB positive, distribution is 2.5% of the population, AB negative is 0.5. We're giving out 11 plus 2.5 is around 13.4 of our issues are AB plasma, and they shouldn't be. Okay, and that's once again some centers now, like in Toronto, are keeping thawed plasma available, AB plasma, and I don't think that's necessary either. It's not necessary in Manitoba because we'd just be wasting it or trashing it. Although the plasma can be kept for, I think it's up to 5 days right now, it might be 7 days after it's thawed, and it's still considered good. So that's the problem we have, and I think the other good thing about plasma is it's dropped off 5% to 8% in Canada over the last 3 years, nationally. Regionally, it's really regional. Manitoba is a plasma user, so our plasma use is higher than the rest of Canada's usually. I don't know why that is. University of Alberta in Edmonton and University of Manitoba have always been colloid users and plasma users, and that still continues. Last year, the CBS actually monitors all the 100 top hospitals in Canada, see what they're using, and there was one point last year where number one for plasma use was UHN, number two was Alberta, Edmonton. University Hospital, number 3 was VGH, number 4 was actually St. Boniface. And that was a blip, and it was corrected, because the CBS will send a letter to the transfusion medicine department saying, what's going on here. There are some different quirks that happened at the time, and actually St. B is off the top 10 now when we looked at the last quarter. But we have to monitor very, very carefully, because O negative and AB plasma, O negative blood and AB plasma are 2 days away from having an acute shortage at some points. We have a green phase, an amber phase, and a red phase following how many units are available in Canada. And those are the ones that we have to fix, because we're going to run into trouble. Between those and platelets, it might be a huge problem. So yeah, once again, the Canadian transfusion rate for plasma is 4.9 per thousand. In Manitoba, it's 8.2 per thousand. There's a lot of it is just, like I said, there are some centers in Canada that have always been plasma driven, and Manitoba has historically fallen into these. The significant reason, though, that I think is that other provinces use PCCs to reverse warfarin. We are pathetic when you compare to, we are getting a wee bit better, but places like UHN, who have hematologists that really drive it home, they have almost 100% compliance with reversal warfarin. PCCs are used and plasma isn't. One of the reasons we have here is that we have to go through transfusion medicine to order it. And I'm happy to report that we're just initiating a pilot for physicians to order PCCs without TM approval, transfusion medicine approval, which I think will be a great thing and long time needed thing, because in other provinces you don't have to go through transfusion medicine to get your PCCs. So I think that's the important next step we have to do. It's hard to get a transfusion medicine person sometimes. Not all of them know what the standard dose is or the correct dose, although I think that has improved. So, well, choosing wisely can make a difference. One of the problems I have is, it's up to individual societies to educate, and I think there has to be a cross-pollination of societies. I've given, I don't know how many lectures to emergency medicine physicians and trainees saying, don't use normal saline, don't use normal saline. Paramedics out there, don't use normal saline, don't use normal saline. Here are the reasons why. Nothing changes. And I don't know, because maybe my KT abilities are not great. I don't know if it's that. But what they want to hear from their own. And hopefully with Choosing Wisely Canada, with the societies actually make them. But they have to make these recommendations. They have to be able to cross-pollinate, as I say. You have to sit down with emergency physicians, with surgeons, and say, hey, why aren't you using fibrinogen concentrate? It's available now. Or why are you transfusing? Why are you giving plasma? It's not necessary. And I think you have to have that dialogue, because I think even changing within your society can become an issue. But what we think of say, an anesthetist of how blood should be used, and what maybe surgeons or critical care people think are quite often two different things. So there has to be some dialogue. As I said, there's much regional variation that can be corrected. Manitoba is unique because geographically it's much like Newfoundland and Labrador. We have the huge one center, and then we have these things spread out throughout the province. And it's really hard to supply blood to a rural area without having it get outdated. And but I think the DSM and CBS has really improved that, in that we know where all the blood is. We have a thing called Traceline, and we can track blood. We can track blood to see which patients got it now, which we could never do before, and that's going to make a huge difference and be more effective. And I said, Canada has the highest rate of IVIG use in the world. And if you want to look at savings, not necessarily safety, but savings, we have to look at that. IVIG should be ideal body weight dose rather than how much they do weigh. And some other provinces have adopted that, but not everybody has. I'm going to stop there, and I just want to follow up with that gynae patient. So that was bleeding, and we ended up calling the master transfusion protocol, and she lost 9 liters of blood by the count in the sponges, and with the fluid therapy that we do, you'd think, okay, she lost 9 liters of blood, which is twice her circulating blood volume. How many red cells do you give? And we gave 9 in total. So it's you'd be surprised at what their hemoglobin is after you've done that with the fluid shifts. And their hemoglobin actually does, as long as they're not bleeding, their hemoglobin does improve. The other thing that I always use this opportunity to do is talk about fibrinogen concentrate. We're doing a trial now that we're going to look at the cost effectiveness of it. There's a good chance that fibrinogen concentrate is cost neutral compared to cryoprecipitate. Actually, it's cheaper than cryoprecipitate when you look at what you're getting inside. I think fibrinogen concentrate plays a role right now in obstetrical hemorrhage, and I've used it once, and it's we have a patient that's with an accreta that's coming up, and I'll make sure there's fibrinogen concentrate available. We only have 6 vials of it in Winnipeg because it's for a person that has primary hypofibrinogenemia that they need it, so that we can order it, and it has been blessed by Health Canada. Nova Scotia has much experience with fibrinogen concentrate through anesthesia in a cardiac program. But I think it's definitely in obstetrical hemorrhage and cardiac, we should be using it more. And this is part of the education that just doesn't exist. And I'm really pleased that the CSTM came up with these recommendations, because I don't think they're for everybody. And I think a lot of us here will say, well, that doesn't work for anesthesia, but a lot of it does. And I just make sure you think twice before transfusing. And I think I've always said the culture of transfusion medicine is cyclical, and it's been shown since 1941. Every 7 years, there's an anxiety above it which goes like this, and usually the anxiety is associated with things like HIV or Hep C and the prion disease. But we are just coming out of for the last 5 years, there's no harm in giving blood. the more information we get from databases for people who get red blood cells, we can compare it to non-transfused patients. There is something going on which, whether it's interleukin or what, there's something out there that's still happening that we don't know enough about. All right, anyway, questions? Thanks. Everybody knows everything? My knowledge translation has just gone up 100%.
So, Dr. Muirhead, I'm interested in the cost per unit of packed red cells, and also how you talk nationally about reduction in transfusion practice. How well is your work working here in Winnipeg? How well are we doing? Because we have blood conservation, and I think it's making an impact in the areas that I work. So, as far as the cost goes, they still use around $500. One of the problems is that all the costing of blood products is based on the red blood cell units. So that $500 for red blood cells includes what it costs to make the plasma or the platelets in the cryo. The other problem we have with the way CBS does their pricing is they have a budget for blood products, and they have a budget for plasma-based products. And it's hard to get, if I say, let's get rid of cryo, they save a lot of money on their blood side, but I say we're going to use fibrinogen concentrate, and all of a sudden that cost goes up on their other side. The budget of Canadian Blood Services is actually plateaued, and depending on what contracts they get, and right now it's the Canadian dollar, which is the biggest bugaboo when they do contracts with American companies for plasma product production. Most people will still quote the $500 in Canada. Some people say the first unit costs $700 and it goes down to $300 and $200 every time it's re-cross-matching. The cost of it is less. As far as local things, I think we made some huge progress in the last 12 years for our joint program at the Concordia. We've reduced it from, at one point it was 1.51 units per patient who had a joint or a hip or a knee done. And we got down, last time I looked, was down to 0.29. Okay, so it's really, really dropped. It's still, it varies from hospital to hospital, it varies from surgeon to surgeon. You see that through all surgical procedures. The last 3 years, Manitoba, which was a leader in plasma in red cell, was one of the leaders in Canada, has actually finally shown a negative. It's gone down. Okay, with the red cells, a lot of it was better distribution of red cells because of our geography. And Newfoundland experienced the same thing. They know where their blood is now, and they can track it a lot better. But we are going down. We're not going down as much as the rest. We're catching up to the rest of Canada, hopefully. But hopefully that trend will continue. The other thing too is the dosing of cryo and plasma is just coming into light. And one of the problems we have with plasma, which might reverse this trend, is that we're probably underdosing plasma when we give it to people with coagulopathies. We're ordering it by units, okay? And when you order 2 units of plasma, you're getting either 500 mLs of plasma, 750 mLs of plasma, or 1,000 mLs, because some of it is apheresis and some of it isn't. So you have to order plasma by body weight. So an 80 kilogram person, you have to give 12 to 15 mLs per kilogram to reverse it. So you're looking at I would order 1,200 mLs of plasma, not 2 units, because you might only get half as much. So that's the other part of the education that has to be done. Same with cryo. The fibrinogen content in cryo is plus or minus 50%, and you probably have to give around 16 units to get your fibrinogen level up over 2 in the average adult. Go ahead.
Thank you very much. I thought that was an excellent talk. My question, I guess, relates partially to my patients, so in the oncology world, and the type and screen. So it's a 2-part question. For a while we were ordering type and screens only in the patients that we clinically thought were at high risk of blood loss, and we got a letter or a notice from one of the PAC units, and I don't remember if it was here or St. Boniface, that said, no, we want it on all the big laparotomies. So part 1 of the question is, when should we be ordering the type and screen? Because obviously all my patients have cancer, but I can tell when I think, or at least I sometimes I can tell when I think there's going to be, increased risk of blood loss versus, a grade 1 endometrial cancer. And then part 2 of the question is, what is, other than time wastage, what's the problem with ordering the type and screen? Because they're not pulling the blood anymore, right?
Correct. I think one of the problems with the type and screening, and we're coming under what's called a CAP review, which is, I forget what it is, something about American Pathology Society of some sort, and they're going to do a CAP review. But one of the advantages of doing a type and screen, if we do the type and screen on everybody, because with the electronic capability we have and trace line that we have 75% of people who've been type and screened are in that bank. They know what their typing is. So we pick up 4 to 12 errors a year where the blood we get is not that patient, okay? And it's picked up because we have the trace line. So I think there is an advantage to having a type and screen just for that information, to have them on record, because it makes things a lot quicker. And if you're running a problem, I know in anesthesia we've all had a problem, specimen not accepted, you have to give another one. And the CAP recommendation is going to be the patients have to have 2 specimens drawn at different times if they've never been type and screened before. So I think we have to look at, no, we should be type and screen everybody. I think if there is the cost is still okay to do a type and screen, because I think the information you get there is quite valuable, especially if they have antibodies or they have a rare blood type. I think it's important to know. But I think what we have to change is elective type and screen has to be drawn in a reasonable manner rather than the morning of surgery, and not calling it a stat request. But the DSM and CBS people might think differently than I do. From that. Yes.
Brian, can you
Yeah. Yeah.
a couple of questions here. As far as typing and screening goes in antibodies, just trying to understand the rationale. There seems to be a catch-22 that you can't really know if someone has antibodies unless you test them for antibodies. So is the rationale that the incidence of antibodies in the general population is so low that it's not worth worrying about?
I think that's one. I'm not going to speak as a hematologist or a blood bank, but I think that's one of the concerns. Certainly, every time you get transfused, your chances of antibodies increase, and it would be nice to know. Having said that, if you have a patient that came in with known antibodies and they're bleeding, what are you going to do? You're going to give them emergency blood, and the risk isn't all that much greater, apparently, than waiting for the blood to be found. And the blood, it might take hours, it can take days to find a blood match. We have one patient here that has to get blood from Philadelphia that's frozen. So, I think it's important to know if they have antibodies. I don't know what the current antibody, how much is out there, what percentage, because it is based on whether or not they've been transfused before. But certainly, with electronic cross-matching, they know the patients a lot better that are. Ideally, everybody should get type and screened. So they have it on record, but that's not going to happen.
And the second part from, can I give you a second part from Pan Am?
Yeah, go ahead.
The RH bit, and then blood, I guess, is the reaction for someone receiving RH negative receiving RH positive blood is not a big enough reaction to worry about if they're alloimmunized? There's the transplacental part, which is really bad, but if you're not of childbearing age, the reaction in the mother or in the recipient itself is not severe enough to worry about. Is that the thought there? That's
the thought. And they used to say, young people shouldn't get A positive blood. It should be A negative, or O positive. It should be O negative if it's emergency blood. And the basis for that is that if you get transfusions down the line further, you will get you could get a reaction just based on the RH stuff.
Brian, I have a question from Seven Oaks. It's Don Petco here.
Yep.
In view of the Liberal cell saver recommendations, should we have a cell saver reservoir in every clinical area. Currently, we have one at the section room on LA2. And another part to that question is, did you use a cell saver in that gynae patient?
I called for the cell saver in that gynae patient, yes. Did I use it?
Should we have a...
But by the time it's set up...
reservoir?
Sorry?
Should we have a cell saver reservoir like we do on the section floor for every clinical area? Because you could have saved red cells while the cell saver was coming.
We do have a cell saver over, like I said, on the labor floor that we can use in gynae. The problem that sometimes happens is setting it up. Some nurses know how to put the 40,000 units of heparin in the bag and how to hook up the two hoses to start collecting it. I think women's is too far away as a problem, and it's going to be corrected, and I think that'll make a huge difference. We after the last one, we used the high pressure Belmont to transfuse, and it was amazing. Susan came over with it from the other side. She ran over with it, and we had 8 units in the plasma in within probably about 15 minutes, which she needed because she was symptomatic at that time. And the cell saver at the time it was ready to go, the bleeding had stopped to some degree. Okay, I got 2 more quick questions, I think, over there.
I'm Devin, one of the gynae residents. I had a specific question about frequency of type-in screens in our obstetric population. So, as we have more C-sections, we're seeing more and more invasive placentas and more patients admitted to the ward for months with placenta previa or placenta praecreta or accreta or increta. And we're ordering type-in screens every 3 days on those patients for months. I was just wondering if those patients haven't had a blood transfusion in the last 3 months, could you do a type-in screen that lasts for 21 days as long as they...
Unfortunately, no.
No.
I think because of their pregnancy, they could develop antibodies at any point. I think that's the reason. Savis, would you say that's the reason? There could be some placental yeah. Brian?
Thanks, Brian. That was a lot of good recommendations. I appreciate your comments about reversal of warfarin. I'm not offended or take issue with any of it, but I don't know of any hematologists who are not saying given PCCs. I'll make sure my colleagues are aware of that, but I don't think that comes up. If anyone else feels that's an experience, then they should call myself or Don Houston, regardless of who's on call, and we'll make sure that that's sorted out. I just don't see that happening. I do think that the fact that you have to get transfusion medicine or hematology to prove it is the stumbling block, and people would rather just give plasma than talk to another schmuck in the middle of the night. So, I think that's part of the problem.
Thanks, Richard.
I think also our use of preoperative testing may drive other tests and plasma use. We are a higher user of Canada, highest use of plasma in Canada, one of the highest, I think. And I think cardiac surgery is a big part of that, and I think our practices there are a little bit outside the bell curve. But some of that might be driven by preoperative testing, which still goes on. And I know there's been efforts by anesthesia colleagues to change this with choosing wisely, but the preoperative PTT thing needs to be addressed by anesthesia. So anesthesia needs to get their act together, as opposed to hematology need to perhaps getting their act together in PCCs, because we generate a lot of consults from the asymptomatic PTT probably every couple of weeks from somewhere in the WRHA, for which is, well, are we going to give plasma to this person, or what's going to come up next when it's an asymptomatic person with no bleeding history for which the test shouldn't have been done?
Tom over at, still at Pan Am, did you look at PTTs in your pre-op testing?
I think HemePath or hematology solved that for us, and I got a gunshot email that was sent widely to everybody that notice to all doctors PTT won't be done unless it's approved by a hematologist. So I'm anticipating that it's going to become impossible to get a PTT done effective now, because I think that took place either October 1st or November 1st.
Unless the patient's on heparin.
Did you know that, Ryan, or am I mistaken on that?
Yeah, I didn't think it was going to be that draconian, but sounds like it could be effective.
All right, thanks a lot. There's coffee and, sorry, is there any other questions?
Yeah, just one more. What do you think about the recent opinion that cancer patients are different in terms of tolerating anemia post-operatively, and maybe should have a bit of a higher threshold than we would for orthopedics or other general surgery patients?
I can't give you an answer to that. I think Ryan's gone, but I think it depends on the type of cancer. There is some immunomodulation effects other hospitals looked at in the bloodless hospitals, and they say there is a poor outcome in patients who get transfused who have cancer. It's not just cardiac patients or patients who get a sepsis or infection from it. So that question is still unanswered. People are looking at, if you're going to transfuse a person for heart surgery, you should do it 3 days before, so the inflammatory response is gone by day 3 when they're having their cardiac surgery, and you won't get the renal complications that you see with people who are transfused. I think that'd be, like Keelan Karkouti is looking at that. I think it'd be a hard one to pass ethics to have a person transfuse 3 days when they don't need the transfusion. All right, there's coffee and dainties out there. Thanks.